discussing a femoral neck fracture in patient younger than 50 years of age. These happens due to high energy injury in patient less than 50 years age with normal bone, affecting extremity shortened, external rotated with painful range of motion. Neck shaft angle is 132 plus minus 7 degrees with 10-degree anteversion plus minus 7. Calcar is a dense bone which is placed in posterior medial aspect. Cartilage has 3 to 4 mm capsule and labrum. The blood supply is important, and as greater the fracture displacement, greater the vascular compromise. A AP lateral view is advised. A AP to compare the contralateral side is important. A traction AP view is indicated to distinguish between the intertrochanteric and femoral neck fractures in community or significant displaced fractures. A CT scan may help to diagnose rare circumstances with non-displaced fractures. MRI is highly sensitive than CT scan but rarely is required. It can be subcapital, transverse, or base or microfractures classified as per Gardner classification. Type 1 is valgus impacted fractures, which are incomplete. Type 2 is non-displaced fracture. Type 3 is complete or partial displaced fractures. Type 4 are complete displaced fractures. Powell classified it with a horizontal line, and the angulation is assessed with grade 1 less than 30 degrees, grade 2 30 to 50 degrees, and grade 3 more than 50 degrees. More vertical the fracture pattern, the more instability it is, and more shear forces are transferred while weight bearing. Traction is typically contraindicated in these patients due to concern of increase in intra-articular pressure and possible tamponade effect. It's a surgical urgency, not emergency. Early, generally the better. The goal is 12 to 24 hours. The timing of the surgery has become less controversial with the passage of time. Previously, the articles by Jane and Duckworth showed that more than 24 hours of delay might increase the risk of failure of the implant with more chance of non-union, that is more than 12%. Recently, Razek et al. In 2012 retrospective study showed that the AVN risk is around 13% and there is no difference between timing. Regarding the definitive management, either you can do a open reduction fixation or a closed reduction. Regarding the open versus close, 2010 to 20 years back, there was the predilection towards open reduction. Anatomical reductions and stable internal fixation gives the patient best opportunity to avoid complications. We have to avoid varus, angulation, and posterior tilt. Recent data has shown that close reduction there is 2 to 4 folds increased risk of reoperation when open reduction without improvement in reduction quality compared to the closed group. There are 2 ways to do open reduction. Either anterolateral approach, that is basically lateral incision over the greater trochanter, superficial dissection, incise iliotibial band distally, continue towards anterior half of greater tuberosity, incise fascia on the posterior aspect of TFL, deep dissection between TFL and gluteus medius, and then exposing the head. Anterior approach is Smith-Peterson approach. That's anterior incision between the incision from the iliac crest to the just proximal to the anterior superior iliac spine. 10 cm distance aimed towards the lateral aspect of patella. Superficial dissection is between sartorius and tensor fasciae lata. Sartorius is supplied by femoral nerve and tensor fasciae lata by superior gluteal nerve. Avoid lateral femoral cutaneous nerves. Ligate some branches of ascending artery. Rectus femoris and gluteus medius plane is achieved. Rectus femoris stenotomy may be needed. Exposure of the hip joint by capsulotomy. The anterior approach, when done, a lateral approach has to be employed with it for implantation and insertion of screws. Right. Comparing the two approaches, a Smith-Peterson approach is excellent for visualization of all femoral neck fractures. Easier application of anterior and medial buttress plate, requires separate lateral incision for implant insertion. Watson-Jones approach is optimal visualization of subcapital fractures. After visualization of all fractures except subcapital fractures, and it has good visualization of base cervical fractures, and difficult to place medial plate or a buttress plate. So implants are placed conventionally through the same approach. Regarding the reduction technique, there are multiple ways. Number one is pointed reduction clamps can be used. One of the clamp moves toward the femoral head and the other the greater trochanter and try to reduce the fraction. Second is a K-wire technique, putting K-wires and Schwann pins. The third technique is by the Smith-Peterson approach, reduce the fraction and apply a medial anti-glide buttress plate, or a provisional K-wire fixation done and then placing a definitive fixation. In some situations, collinear clamps can be used to reduce it. Regarding the type of implant, a sliding hip screw plus anti-rotation screw can be utilized. A sliding hip screw plus a medial buttress plate is possible. A cancellous screw is possible. Regarding the cancellous screw fixation, there should be inverted triangle, the inferior screw within 3 mm of cortex and the posterior screw within 3 mm of cortex is important as per Booth et al. In 1998. At least more than 5 mm of the threads should be in the subcortical bone. Multiple around the world fluoroscopic assessment should be done so that screw is not intra-articular. Beware that the starting point should be below the lesser trochanter. The starting point should not be below the lesser trochanter to avoid stress risers. Regarding fully or partially threaded screws, there is a controversy. A partially threaded screws allow interfragmentary compression at the fracture site, can lead to excessive shortening and malunion, abductor weakness, limb and limb dysfunctions. A fully threaded screw cause limited compression and is a cause of concerns, but may prevent excessive fracture collapse, especially in femoral neck fracture with posterior wall comminution. Regarding sliding hip screws versus cancellous screw, a sliding hip screw is more feasible for base cervical fractures, improved stability in comminuted fractures, versus cancellous screw, which is less invasive and probably improved rotation control. Faith 1 study was a study conducted in more than 50 years old patients. The sliding hip screw showed failure with screw cutout and is better for base cervical fractures, better for smokers, better for displaced fractures, higher rate of AVN is noted, and more patients are converted to total hip replacement surgery. Regarding the cancellous or cannulated screw in Faith 1 study shows that it fails by varus collapse and hardware prominence. Higher incidence of implant removal is also noticed. Regarding non-union, fixed angle plate devices have non-union of 9%, while cannulated screws have non-union of 19%. Then Phase 2 study, a pilot study was done. 86 patients were enrolled, less than 60% of age, comparing sliding hip screw versus cancellous screws and vitamin D supplements versus no supplements. The study takeaway were that complication rate remains high, 28%. Sliding hip screw and cannulated screws have similar complication rates. Sliding hip screw fails by screw cutout, cannulated screw fails by varus compromise and varus collapse and hardware prominence. When considering ipsilateral femoral shaft fractures, is the 5 to 10% of femoral shaft fractures femoral shaft fractures can be with femoral neck fractures. Frequently, the fracture is vertical fracture and they miss in 30% of the cases. MRI short coronal T2 sequence has been advised as a screening tool but is not practical. Regarding the fixation, modern plate fixation systems are available for fixation, and a plate is also possible. Arthroplasty should be considered in any patient in which the patient is more than 40 years of age, history of renal disease, history of renal liver disease, history of respiratory disease. This to be shown by Duckworth et al. JBJS 2011. Regarding capsulotomy, it has been quoted that it reduces intracapsular pressure from hematoma formation. But it's not clinically relevant, and increased capsular pressure is not associated with AVN, as per Marenda in 1997. Rehab regarding stress fractures, they can be either fixed with cancellous screws or a screw plate construct. Regarding patients who have non-union or a delayed presentation, a valgus intratrochanteric osteotomy as per Powell has been advised.